Hello, everyone, and welcome to the Empowering Women podcast. It is our second episode in Women's History Month. This month, as many of you know, it's meant to recognize the specific achievements of women and what they've made over the course of American history in a variety of fields. Today, we will discuss an area where women are and have made huge contributions, yet unfortunately, there's still a long way to go, and that is health equity. This is a hardship for many women, particularly Black women and women of color. And I and you should be absolutely honored today to have Dr. Nicole T. Rochester with us. She's a board certified pediatrician, a TEDx and keynote speaker, and the CEO of Your GPS Doc LLC, which is an innovative company committed to eliminating health disparities and bridging the gap between healthcare providers, patients, and family caregivers. Welcome, Nicole, to the podcast.
Thank you, Shannon. I'm really excited and honored to be here.
Yeah, I am super honored to have you here, especially with this conversation. The place that we all love to start on the Empowering Women podcast is to learn more about the journeys of our guests. So let's start with you telling us more about your story and what brought you to this place.
Wow. Well, my story starts back to when I was like 8 or 9 years old, which is when I decided that I wanted to be a physician, and not just any physician, but a pediatrician. And so it was a lifelong goal of mine, something that I proudly announced to family members and classmates and teachers. And ultimately, went through that entire process of becoming a physician, becoming a pediatrician, and had a job for the majority of my career that I really loved, and honestly, a job that I thought I would be in for the rest of my career.
Mm.
It had a combination of practicing medicine, taking care of children, which of course was my primary love, but also I had the opportunity to teach, which was my secondary love. So teaching medical students and residents, which are those in training to become pediatricians. And then I also was the medical director, so I got to wear an administrative hat. So it was really the best of everything. And during that time, my late father became ill. He had been ill for a while with a lot of chronic medical conditions, but around 2010, it's like everything just kind of all came to this height. And he was really no longer able to care for himself. And my two older sisters and I had to rather abruptly jump in and begin caring for him. And while I didn't necessarily identify myself at the time as a family caregiver, I became a family caregiver at a time in my life when I was also managing, work and marriage and two kids and all the other things that go along with adulthood. So it was a very difficult time. But what I discovered that I was completely not expecting was how difficult it was to navigate the healthcare system. And my two sisters and I have different backgrounds. One is in healthcare, one is not. But we ultimately kind of divided and conquered and decided that we would each be in charge of certain aspects of our dad. And so I, as the doctor in the family, I was the one that was in charge of overseeing his healthcare, which meant going to his medical appointments and talking to the various doctors and other members of his medical team. And for the 3 years that we cared for him before he passed away, I found myself in situations over and over and over again where I had to very powerfully advocate for my dad to make sure that he received the appropriate medical care. And it wasn't something that I was used to in pediatrics, where everybody just kind of falls over and makes sure that all the kids get what they need. I felt that he was being ignored, I was being ignored. And so that journey of learning how to advocate for him, and also recognizing that I was doing it from a place of privilege as a physician, so an insider, so to speak, it really made me want to do that same thing for other people. And I just kept thinking, if it was this difficult for us, one of my sisters is a nurse, I'm a doctor. Between the two of us, we probably had 30 plus years of experience in healthcare, and yet it was still quite difficult. So what is it for normal people, quote unquote, lay people, let's say, who haven't had that experience? So to make a long story shorter, I went back and he passed away. I continued to work. I still had joy, but I just couldn't ignore this nagging that I was supposed to be doing something else. And so eventually I left clinical medicine and started my company, Your GPS Doc.
it's a sad but beautiful story. I'm so glad you were able to be there for your dad. And now being a caregiver myself, for my mother, I really understand what you mean. So just a quick short story. Um, my dad passed away unexpectedly from a heart attack. And at the time, my mom was having some gastrointestinal issues prior to his passing. And as you can imagine, they'd been married for a long time. So immediately following his passing, she regressed and she was set to go for an endoscopy so they could take a better look. Well, obviously, that wasn't a good idea. In those, couple weeks following his passing. And it was really hard, Nicole. I have an engineering degree, so I have a scientific brain, but I'm not part of the medical field. It was really hard getting through to people. I mean, to the point, honestly, I called them crying because I just lost my father. And I'm like, I'm watching my mom deteriorate because she can't eat. And I mean, it was to the point where I was crying on the phone to the folks in the office to get them to understand that this was serious and that they needed to help me come up with a containment plan, so to say, until we could start moving down the corrective or preventative plan. So I'm right
Mhm.
there with you. I felt invisible. I felt not heard. And
Yes,
I'm sure I'm one of millions of people that can share that story.
absolutely. I'm sorry to hear about your dad.
Oh, thank you so much.
You're
Yeah.
welcome.
So, well, same for you. I know
Thank you.
that's been mine's been about 4 years ago. So it sounds like, we went through it maybe during similar times, but yeah, it's really, really tough. But I think I shared this with you in the notes prior to the podcast. So this might take me just a few minutes to read. But I recently read an article published from Boston University. It was entitled Racism, Sexism, and the Crisis of Black Women's Health. And what I didn't know, what I learned was that the article is based on a group of 59,000 women, and the largest and longest running study in the United States focused entirely on the health of Black women. And what was really enlightening for me was this statistic is that Black women are more likely than other racial and ethnic groups to die from cardiovascular disease, hypertension, stroke, lupus, and several cancers. And they are twice as likely than white women to develop diabetes over age 55 or have uncontrolled blood pressure. Blood pressure. But what I knew, I was like, that can't be related to their race. This has to be a much bigger problem. So I'm curious, based on your experiences as a doctor, how do you think racism and or sexism play a role in what I think are troubling statistics?
Yeah, thanks for really like highlighting that article. And it really summarizes, I think, what many of us know and what many of us have seen in practice for decades, and certainly what I've seen with members of my own family. And I appreciate you saying and leading with the fact that this is not due to race, because what we know now is, and what's always been true, is that race is a social construct. And
Yep.
if the Human Genome Project proved that we are
Yep.
like 99 point something percent all alike. And yet I can tell you that when I went to medical school in the mid to late 90s, lecturers regularly talked about the fact that Black people had higher rates of this and they died more from this. And there wasn't, I won't say they explicitly said it was biology, but there was definitely an implication that
Mm,
we were either biologically inferior or we just didn't care enough. We didn't take good care of ourselves. So I'm really appreciative of the newer research and studies like this that really look at the root cause. So to go back to your question, racism and sexism literally changes your biology. And we know
mm,
that it's a form of stress, it's a form of trauma. And when you are subjected to stress and trauma repeatedly, particularly when you're subjected to it from a place where you don't have the power and the authority to really direct your life to some extent, and where you are not able to escape that, it's an identity and it's an experience that honestly, Shannon, is hard for me to explain, but it's absolutely my lived experiences, and these lived experiences of friends and family members and colleagues. So what we know is that there are literal changes that happen. If we talk about cardiovascular disease as an example, stress and trauma, it changes the hormones that your body produces. It changes, which have effects on your blood vessels. So it makes your blood vessels constrict, which in your kidneys and many of your other organs throughout your body. And that's really at the underlying cause of things like high blood pressure and heart disease and stroke. So there are literal biological changes that result from the stresses of being exposed daily to racism, to sexism. And then we also know there's something called weathering that has also been studied very specifically in Black women with regard to, again, some of these biological changes that happen in your body as a result of stress, and even things that happen to your DNA. So it's really both fascinating and scary, but it also provides an explanation for why, definitely among Black women and women of color, but really among Black people and people of color, why we continue to see these significant health disparities, differences in the incidence of diseases, differences in the outcomes. And then I would be remiss if I didn't add that racism and sexism also impact the care. So we have the biology of it and how it impacts women and women of color, their ability to remain healthy. But then on top of that, we receive different care. And this has also been studied, and this has been proven over and over again as a result of the biases on the behalf of providers that may not even be aware that they have sexist or racist beliefs. And so if a woman of color or Black woman presents for care, we are more likely than white women, as an example, to be dismissed, to be gaslit, for our symptoms to be attributed to other things like obesity, which is a whole nother conversation about why Black women and women of color have higher rates of obesity. So we have these increased risks for diseases based on the trauma and the stress that we're exposed to. And then we are encountering often providers that don't look like us, providers that don't share our culture, and providers that frankly have biases that prevent them from giving us the best care.
Mhm.
So it's a recipe
What
for
does that look
disaster.
like in an appointment? So for a Black woman, what could that look like? Like if she goes in and I don't know, maybe has high blood pressure. I'm making that up, but what would that look like for her?
It can look like being dismissed. So what you and I experienced as a caregiver, it can look like a Black woman going to the doctor, explaining that she is having headaches. I'll just use that as an example.
Okay.
And being told, oh, it's just stress. You need to or it's because you're overweight. You just need to work out more. You just need to eat better. You need to, maybe you're eating too much salt. Some doctors will even make assumptions about the types of food that Black women and women of color are eating without even asking the question, oh, you probably are eating a lot of fried food. You need to cut back on that, or maybe just dismissing them completely. So yeah, it really can be demeaning and disheartening. And then sometimes it can look like either a reluctance or even a frank refusal to institute a detailed workup. So maybe the woman has read a little bit, or maybe she has a doctor friend like myself who has said,
Right.
hey, you need to ask for these particular tests. And maybe the doctor's like, oh, you don't need that test. Just that's not necessary. I don't think you have that. And granted, while we are trained to look for what's most common, that there's more of a tendency with women in general, and certainly women of color, to dismiss symptoms. And so we don't always get that thorough workup that a white woman, as an example, would get with the exact same complaint.
Oh, it just hurts. Like,
Yeah.
I mean, I obviously don't have that lived experience, not from a racial standpoint, but it just hurts for me to think that a woman shows up, goes to the doctor, is trying to find a way to be healthier, and then is just told, oh, you just need to eat different foods. And then to your point, they made an assumption in your example about, oh, you have a terrible diet, and then they have no idea or haven't asked the question.
Mm-hmm.
Uh, you just made a note about Black women and obesity and some assumptions. Is there anything that you could share that might be enlightening to our listeners?
Well, I think, a lot of that, I'm not an expert on obesity, so I want to be
Right.
careful and,
Fair
and,
enough.
and, and state that in my answer. But definitely we know that stress hormones, like things like cortisol, I don't want to get too scientific, but
Right.
when we are under stress, one of the things that our body secretes in excess is cortisol. And cortisol absolutely leads to deposition of fat. So there is a link between, obesity and stress. And then admittedly, there are some practices and cultural practices and food preparation practices within the Black community that can be contributors to obesity. And so there's a whole movement around educating in a culturally sensitive, culturally appropriate way, educating women and Black families around how to prepare some of the things that are maybe important to us in our culture, but how to prepare them in a healthier way. And then if you look at, historically, there's a connection between poverty and lower socioeconomic status and being Black. And again, that goes to racism and just all of the many barriers that continue to exist. And so not even having access to healthy foods. I mean, there are literally today in 2024 neighborhoods in Black communities across the United States where there are no grocery stores. They literally just have access to what people call a corner store or a bodega. And so, chips and snacks and sodas and things like that. And then even if you happen to have access to a grocery store, there's evidence that the quality of the produce and the quality of the foods and things in certain grocery stores are different. And then even if you have access to a grocery store with fresh produce and organic foods and things like that, these days, who can afford that?
Yeah, I was joking with my mom the other day that it's a lot cheaper, especially right now, to eat crappy than it
Yes.
is to eat healthy.
Yeah. And that's always been the case. And that's also not an accident. And so when you have a situation where in order to be your healthiest self, you have to have wealth, you have to have power, you have to have influence. Those qualities are not typically what we see in women and not in Black women and women of color. So there's just so many structural barriers that are preclude one's ability to maintain a healthy weight. Many people live in neighborhoods where it's not safe to go outside. So for a physician, again, without having that context, to just tell a woman of color, well, just go exercise more. Well, can that woman afford a gym membership? Does that woman even have green spaces in her neighborhood to go for a walk? Is it safe for her to go outside when she gets home from work? All of these things are things that typically don't come up in that 8 or 9 minute doctor's visit.
Nope. Are you seeing changes in the medical community that are helping at all? That the medical community is seeing things a little differently?
I think that the main change I'm seeing is there absolutely is an increased awareness. And I will say, since George Floyd's murder and in 2020 and racism being declared a public health crisis and all of the events and opportunities that have come as a result of that, we absolutely have seen more awareness in the medical community. There are more conversations like this happening. What I haven't seen change significantly is the system. So we can educate doctors and nurses and other healthcare professionals. And in their heart of hearts, I know that they want to do the right thing. Everyone wants, I believe, most people want to take good care of patients. But if we don't change the structures in which they practice, the systems in which they practice, I just mentioned 7 or 8 minute visits. How are you going to delve into all of these things that you and I just talked about in the confines of a 10-minute patient visit, where you also have to check their medications and there's so many other things that you have to accomplish. So I think, what I and many others doing this work in health equity would love to see is a change in the healthcare system itself so that these types of conversations are prioritized and so that they're incentivized and honestly in a financial way. I mean, ultimately, we have to pay doctors and other healthcare professionals to do this work, to do the work that's going to produce the outcomes. And so if these types of conversations are not reimbursable, then doctors and nurses and nurse practitioners, they're going to continue to focus on what they have to do to get paid.
Yeah.
And that's just the reality.
Yeah, and I've experienced this myself, and I'm sure it's some constraints on the payment side and maybe some of the logistics of being a profit-driven business in many cases. The doctor and or nurse practitioner has said you have X amount of minutes on average to spend with a patient. I don't know that for a fact, but based on some of the quickness of my visits, I think that's probably what's going on behind the background.
Yeah, for sure. And I mean, there's all types of productivity calculations that many healthcare providers are subject to. And if they are not efficient and seeing a certain number of patients per hour per day, some of them are penalized for that. So
Mm,
again, the incentives are not aligned properly.
interesting. Well, when I read the article, Nicole, I knew this, but it was really hard to see it in print. It says much of our clinical research has been based on white males. And I knew that, but it was, again, it was different to see it. Do you think that's changing at all?
It is changing. And again, because of all of the impetus behind health equity and diversity, equity, inclusion, specifically in healthcare, we are seeing changes. In fact, the FDA, the Food and Drug Administration, has new regulations. There are little like laws in place to make sure that clinical trials are more diversified. And so there's a higher standard that people who conduct clinical trials now have to meet with regard to, race and ethnicity, with regard to gender. So we are seeing some movement in that area. Certainly, like everything else we've talked about, there's a lot of growth that still needs to happen. But again, there definitely is an increased awareness. There's even some regulation around that. And
Okay.
I'm seeing a lot more in the area of outreach to communities, diverse communities, to make sure that they're at least aware of the importance of clinical trials. Where there's still areas for improvement are making sure that that clinical trial workforce is also more diverse, because we know there's a huge, there's a lot of mistrust and distrust that was well earned from the healthcare industry in communities of color. And so while there are initiatives to increase the diversity of clinical trials, the messenger is very important. And so, as a Black woman, I am naturally going to connect more with someone who looks like me, someone who has my lived experiences. And so if that person is coming to my church or my community organization and encouraging me to participate in clinical trials, it's going to land differently than if
Yep.
a white male, as an example, comes and gives that same talk. So, one of the other initiatives is diversifying clinical trials, but part of that is going to be diversifying the clinical workforce, the research workforce, the pharmaceutical company workforce as well.
Do you think that's happening? This is probably a tough question, so if you don't know the answer, it's fine. I'm curious if that's happening in the medical field, if more Black men and women in particular are graduating and practicing.
I think that remains to be seen. I mean, I
Okay.
definitely am seeing more programs that aim to increase the diversity, even, in medical school, some of the other professional schools, nursing schools, pharmaceutical schools. I think that it's a little too early to really say like the results of those efforts. But what I will say is that, I still represent Black doctors are 5% of
Oh
physicians. And this
gosh.
is in
It's worse
2024.
than engineering by a long
Yeah.
shot.
And Black female doctors like myself are like 2%. If we look at like Native American physicians, I mean, it gets lower and lower and lower. So I don't think we have yet seen this significant increase, but there are some schools that are doing a lot. And so we are seeing that the incoming classes are more diverse. There's still a lot of work to be done, especially with, I know we're focusing on women, but I just want to say
Yeah.
with Black men,
Okay.
there's some statistics that those numbers look like they did back in like the early, mid 1900s. So we have a lot of work to do in that area, but there absolutely is an awareness, and there are initiatives that are taking place right now to increase that. So I'm excited. I guess I'll say that. I'm
You're
excited.
cautiously optimistic,
Yeah,
right?
there you go. Cautiously optimistic.
I think it's really interesting because not the same clearly, but with computer science and engineering, there's a lot of different for racial and gender equity in STEM starting at very young ages. But then, I think I just saw chemistry, that chemistry is about half and half for chemists. So women are getting really close there. But when you look at computer science and engineering, even though we've done all this investment, particularly with women, but even, marginalized groups as well, we're just not yet seeing it, kind of to your point,
Mm-hmm.
in the trickle down And I think Black women, the last stat I saw was about as bad as what you just said with the female doctors. I think with Black women, I think it's like 6% of the engineering workforce. So I think it's funny. I think those two different disciplines are taking a parallel, and
Yes,
that we're investing, but it's not yet tipping the iceberg.
that's right. And with some of the recent attacks on, race-based admissions,
Mhm.
and I mean, this, it's going to become more difficult.
Yeah, that's tough. Well, I can imagine that connection, it again, you just made me think about privilege. When I go to the doctor, I don't even think about seeing somebody that looks like me. I do struggle a little bit with women, but I think more
Yeah.
white women particularly go into nurse practitioner, and that's often who you see if you
Hmm.
go to a general doctor's office just for normal health care. So I don't even think about it. And now you've got me thinking about when's the last time that I saw a Black man or a Black woman in one of those roles, and I can honestly tell you I don't think I've ever seen it, which is
Wow.
a sad fact to say. So, thank you for lifting that veil off of my eyes this morning.
You're welcome.
We talked about this earlier, but I want to make sure there's others that we missed. So, one of the questions I had for you was, what obstacles do you see for marginalized groups to access quality and affordable health care? We talked about some of them, but I don't know if there's any in specific that we missed, or you might want to go back and revisit.
Yeah, I think some of the obstacles, one of the main obstacles is not just insurance, because I think that people naturally default, when we talk about these disparities that you and I have been discussing, some people say, oh, well, that's just because they don't have health insurance. But the reality is that, particularly with the institution of the Affordable Care Act, the percentage of uninsured Americans is really, really low. But the reality is, if you look at even among those who are insured, if you look at people of color, again, there's these disparities in the types of insurance, the types of coverage. And then if we even look at the differences between insured and uninsured, so Black people, people of color are more likely to be employed by companies and organizations, or in roles that may be part-time, that may not offer comprehensive benefits. And so they may have a health insurance plan, but it may be like a high deductible health plan
Mm.
where your deductible is $2,000, $4,000, $5,000, $10,000. And so you don't really have insurance when you have a deductible of $5,000 or $10,000, because what that means in most cases is that anytime you seek medical care, you're paying for that out of pocket until you reach that deductible, and then your health insurance benefits kick in. So just the very access to healthcare providers, if you're worried about paying your rent or your mortgage, putting food on the table, all of the other things, utilities, all the things that go along with living, you're going to defer your medical care. And we see this over and over again in marginalized communities, is that they are, I would say, appropriately choosing, food and housing over, oh, I've had this ache or this pain for the last 2 weeks, and I know it's not normal, but I don't have the money to go get it checked out. So there's that with regard to like health insurance and just access and finances. And then we talked about it a little bit, but the mistrust also, even when you have access. I mean, again, I'm a physician, so I have, my family in general, I would say most of the members of my family classify as middle class. And I will also share that many of my family members, even though they know that I'm in the industry, mistrust doctors, mistrust the healthcare system, and have care-seeking behaviors that sadden me, frankly, because they have had negative experiences in the healthcare system. And I think that's something that's not talked about often enough, is that we often blame people. Oh my gosh, I can't believe that she took that long to go get that problem checked out. But the reality is, if you've been, dismissed or even discriminated against in healthcare settings, or your family member has, then why subject yourself to that type of abuse? Really, frankly, is what it
Right.
is.
Yeah.
So there's care-seeking behaviors that also just counter, and they amplify some of the health disparities that we've been talking about. So I think we've already really talked about some of the reasons
Yeah.
for the disparities. There are so many.
It's interesting that you talk about the higher deductible plan, because for me, like with the plan that I have the opportunity to continue to invest in an HSA, and I have the financial means to do that. Right.
Yes,
So what I'm gradually building up over time with the help of my company and my own money is that buffer. So if, like, I had a minor kidney stone issue and there was the ambulance bill and some other things, right? So it wasn't
Mhm.
anything catastrophic, but I can't imagine if you're already sort of living on the edge, getting that bill back and going, how in the heck am I going to pay for this? And oh, by the way, how am I going to put healthy food on the table? Because it costs X amount of percent higher than the crappy stuff I'm not supposed to be eating.
Exactly.
Yeah. So it's a pretty fine balance, especially if you're in a lower income bracket.
Hmm.
Yeah, that's tough. So I'm gonna switch topics on you a little bit because I know with your TEDx talk you hit on this a little bit. So there was a December 2022 LinkedIn article, and it referenced a term called the empathy gap. Um, and it was a term used in a documentary that was entitled "The Color of Care." Can you explain more what that term means to our listeners, and then what that looks like in a doctor-patient relationship?
Yeah, thank you for mentioning that. So yes, in December, I actually was flying home from an event, and I had recently watched this documentary, The Color of Care, which I think was produced by Oprah Winfrey and others.
Mm.
And Oprah used that term, the empathy gap. And so on the plane, I was just struck. Like I literally, normally it takes me a long time to write articles, but I wrote the entire article on like a less than 2 hour flight, because I was just really torn and also like intrigued with this idea of the empathy gap, which really, empathy is our ability to, in the simplest terms, put ourselves in other people's shoes. And it's something that I think most of us, if not all of us, have been introduced to probably in kindergarten or by our parents or grandparents, doing to others as you would have them doing to you. And just this idea of, um, being able to feel what other people feel, and much of what we've been talking about, this idea of understanding the context behind an individual's beliefs or their thoughts or their behaviors. And in the documentary they were describing some very disturbing things that happened during the COVID-19 pandemic with regard to Black people. And there was this, one instance where the family member was just describing how they didn't care, like the healthcare providers behaved in a way that they didn't care. Like there was, if they had cared, if they had had empathy in their heart, there's no way they would have been able to do some of the things that they did and dismiss patients and send them home despite the fact that they couldn't breathe and things like that.
Mm.
So, as you stated, in my TEDx talk back in, I think that was 2019, I had talked about invisibility and my experiences caring for my dad and what I perceived to be a lack of empathy, and just kind of dismissing his needs, dismissing my concerns. And so in the article, I really talked about what would it look like. Like I believe that healthcare would look completely different if we all approached patients and families with empathy, and if we really took the time and explored and invested in understanding how our patients got to where they are. And it's really just this idea of meeting people where they are. Like in some ways it's such a basic thing, but again, the system is set up in a way that just really doesn't make it easy to do that. And then also in our medical training, frankly, we're still being taught this idea of like, be empathetic to your patient, but don't get too close to them, and don't express your feelings and keep this wall up because otherwise
Mm.
you're not going to be able to do your job well. And so I think many of us are doing this
Mm.
dance of, I got into this field because I want to care for people. And I'm being trained and I'm being told, and the system is set up in such a way that I'm not really allowed to get too close to my patients. And so there's like this disconnect, or this, like, it's almost like a cognitive dissonance. Like I need to, in order to be a good doctor, in order to be a good healthcare professional, I have to demonstrate empathy, but I have these time constraints. And if I do it too much, I'm going to get burned out, and all the things that, so it's like everybody's trying to figure out where this proverbial happy medium is. But really the empathy gap is just this idea that we have prioritized profit over care. and in healthcare, and that it's literally killing patients. And so what would it look like for us to really prioritize um, the care of our patients? And what would it look like for us to put humanity first and to really begin to connect with our patients in a way that um, allows them to trust us? And just that in and of itself would really repair some of the fractures to that doctor-patient relationship. And I believe it's really what we need to transform healthcare.
Yeah, because in your TED talk, you talk about before you shared with his medical team that you were a physician as well. There was sort of this complete before and after.
Yeah.
And it's funny why they could. It's almost like they assumed that you had no capacity to understand, right?
Yes.
Before you shared, and I've experienced not the same, but something similar for my own care. I had a doctor do the same thing, and I happened to mention I was an engineer, so I think he assumed, oh, well, she's got a scientific brain, so I can actually explain this. And I was like, well, you could
Yeah,
have explained it before. You might have had to simplify it from your understanding, but you could have still explained it.
exactly. And I just want to add, Shannon, it's even deeper than that. Part of it, you're right. When they found out I was a doctor, it was like, oh, now I can use maybe medical lingo. But more importantly, it was that I deserved it. Like I earned
Mm,
the right. It wasn't just about me having the intelligence, so to speak, to be able to communicate, in doctor talk, but it was really
right.
like, oh, she's one of us. And I was
Mm.
literally like elevated, like, oh, now she's more important. And that's what really frankly pissed me off, if I can say that on
Yeah.
your
Yeah, you can
podcast.
say pissed off. That pisses
Um,
me off, and I
yeah, like
wasn't
it,
even
it
there.
really, really pissed me off because it's like now that you know what I do for a living, now I'm suddenly more important than I was 2 seconds ago when you didn't know that I was a doctor. And now my dad is also more important because he's now the dad of a physician. Ugh, just thinking about it, it's been
Yeah.
years, but I'm getting angry just thinking about it.
Sorry. Didn't mean to make you angry this
No, it's
morning,
fine.
but but it makes me angry because now you've really kind of pulled another veil off my eyes. They treated you as an other is what I'm gonna
That's
call it.
it.
And then they're like, oh no, she's actually one of us, so we can do this differently. When at the
Yeah.
end of the day, nothing was really changed other than maybe you had the training to
Uh-huh.
better understand what they were talking about. But other than that, nothing had changed.
That's right.
Ah, that just frustrates me. Okay. Let's go to something positive. You are an amazing thought leader in this space. So I'd love for you to tell our audience more about your company, your GPS doc, like what your mission is and how you're transforming healthcare.
Thank you, Shannon. One thing I love about my company and about what I get to do every day is that I think for maybe the first time, I am able to really bring all of the pieces of myself. So when I engage with clients, whether it's patients and family caregivers and helping them understand and navigate the healthcare system. So in that space, it may be virtually attending an appointment with them, sometimes on FaceTime, sometimes on speaker, and literally kind of engaging with them, with the medical team, or it may be preparing them for doctor's visits, preparing them for an upcoming surgery, making sure that they understand the types of questions that they can and should be asking in medical settings. Sometimes it's bridging the gap between the healthcare team and the patient and their family members. And again, that lingo that we talked about, like literally being the interpreter so that they fully understand. And sometimes it's directly advocating for the services that they need. And then in the consulting and speaking space, where my primary clients are healthcare organizations, hospitals, health systems, healthcare nonprofits, pharmaceutical companies, physician groups, being able to show up in that space also. So I get to wear my doctor hat. I get to wear my former family caregiver hat. I get to sometimes wear my patient hat and reflecting on the experiences that I've had in healthcare settings, as a Black woman, as a mother. So I really, really enjoy what I do. And from the health equity consulting and speaking, I think what's unique is that I am able to bring all of those different lived experiences along with the expertise. And really, I love working with healthcare organizations who are truly committed to improving care for everyone and specifically for marginalized communities. And so helping them to evaluate their current policies, their current systems, their current structures, and then doing it with an equity lens and really uncovering the blind spots that hide beneath these policies. And again, because no one like sets out to provide different care or disparate care. It's really baked into what we do every day. And so helping them to uncover some of the aspects of their policies, their procedures that actually produce and perpetuate health inequities. And then the fun part is then helping them to develop strategies around, improving the care. And that starts, I talk about my inside out approach. So when I work with healthcare organizations, we have to start with the company. We have to start with the leadership, the staff, the employees, because we all harbor biases and beliefs. And so we can't, as a company, or I say you shouldn't, as a company, go forth and want to improve your external clients if you're not also paying attention to what's going on internally and how you're treating your own employees. Do they feel welcome? Do they feel included? Is your own workforce diverse? Is your board diverse? Is your leadership team diverse? So it's fun to both do the work internally with organizations and then see that translate into how they engage with their patients, their communities. So it lights me up. Like I literally wake up every day excited to get to work, excited to work with my clients.
So it sounds like you do both individual, I'll call it coaching or participation, and then you work with corporate and or healthcare clients, kind of fix the system. So it sounds like you're playing both ends. Is that a fair statement?
Yes, and I will say more recently, as my corporate work has gotten has increased and more demanding, I haven't had as much time to devote to the individual. It's called professional health advocacy is kind of the formal term.
Okay, thank you.
So yeah. So I still continue to do that kind of more collectively with like education and blog articles and social media. But yes, that is the idea around it. Is really, as I was working with individuals, I'm hearing the same things come up over and over again. And what I realize is that I can have a greater impact by working with the healthcare organizations and the systems in which we receive care. So combining all of that is what makes me.
Well, it sounds like you have the inside outside approach. Are there any things that might pique our audience interest that they could share with potential employers or clients, like the frameworks that you use?
Yeah, I think in terms of that inside outside approach, again, what I have found fascinating is the process of engaging organizations, their staff and employees, as well as their leadership, their board, in conversations about race and in conversations about discrimination and racism, and really uncovering some of the beliefs that many people have and some of the beliefs that they don't realize that they have, and these implicit biases that literally all of us have, and doing it in a way that is not shameful or blame. It's not, the idea is not to shame people. The idea is not to blame, because that doesn't lead to productive outcomes. But it's really just an introspective self-examination process that really, like, you can see the light bulbs come on. And once you are able to have those conversations internally and really explore, I think it helps organizations to then better understand how communities of color, patients of color, marginalized communities are impacted by their policies. And so it really starts with just having some of those frank conversations, which usually are facilitated. There's workshops and exercises that I employ for that. And then from a speaking perspective and training, also providing education and information that helps individuals understand how we got here. So there's a talk that I give called Dismantling Structural Racism and Bias in Healthcare that really takes you all the way back to like the origins of modern medicine in the United States and how that was deeply entrenched with slavery and the abuse of Black bodies and, all of the things that happened with our indigenous populations and to women. and leading that up to an understanding of why we have health disparities and health inequities in the first place, and then ending with solutions. What are things that companies can do to really change the way that we work and also improve outcomes. So I present information in a way that really allows people to lean in and to like go internal, but then also that informs what they do externally. And then it's that solution, building those solutions so that we do better. I mean, once we know better, then we have to do better. That's one of my favorite quotes by Maya Angelou. When you know better, you do better. And that's what I'm seeing, is that when organizations have that information, then there's a genuine commitment to do better.
Yeah, it's interesting you say that. The thing that I've really learned the last 6 months is about the term privilege, and it's really like invisible things like you talked about with the doctor's office. It's having the aha moment for one. It's trying to fight the shame that comes from it. And then third, it's like, okay, now what am I going to do with it? Like, how can I understand that I have privilege. In some cases, I probably can't change it. So how can I leverage it?
That's it.
To benefit others. So that for my Caucasian folks out there, that's really what you need to think about. You have them, it's everywhere, and you likely don't see it because that's the definition of privilege. And then somebody shows it to you, like you showed it to me today, and they're like, oh, now it makes sense. Yeah. I have one more question for you. Well, technically two, but one final question is there a piece of advice or quote that you'd like to leave with our audience today?
Oh, wow. I think the main piece of advice the quote would be the one from Maya Angelou, when you know better, do better. And the piece of advice I would say is really to treat others the way you want to be treated. And I know that that's very cliche, but it really goes to the heart of that empathy gap that we talked about. It goes to the heart of recognizing bias, and being willing to examine our own biases and then to dismantle those biases. And it goes to this commitment to the hard work. I think one of the things that's most difficult about doing work in the diversity, equity, inclusion, health equity space is that it really is hard work. You can provide individuals with frameworks and strategy and all of those things, but ultimately it's hard work. And for those of us that do it, I mean, there are a lot of tears involved. I cry a lot, sometimes happy tears, often sad tears, frustrated tears. So I think just an acknowledgement that there are systems and structures in place that have been in place for centuries and that were not eliminated with civil rights legislation, all the things, like wonderful things that happened in the 60s. But understanding that in spite of the wonderful, I am not discounting the gains that we have made in this country with regard to gender, with regard to race, all of those things. And there is still a lot of work to be done.
Yep.
And so just understanding that everyone really is doing the best that they can. No one wants to be sick. No one wants to be poor. No one wants to be unhappy. And so when we meet individuals in those spaces, really connecting with the humanity that is in them and actively looking for the ways that we are alike, because that's what bridges that empathy gap. Don't see me as a Black person or maybe even a woman, but like see me as a human. See me as a Black person. Let me be clear. Like, the colorblind.
Don't do the don't see color thing.
I don't subscribe to color blindness at all.
Me either.
See me as my full self, but see my heart and recognize me as a fellow human. And let's look for the ways that we are alike.
Yep, absolutely. Well, you've gave some intriguing talk. I'd love to hear that one keynote, by the way, about the racism through the years and how that's really built up into where we are today. So if folks want to find you for a keynote or a healthcare organization wants to find you, where can they find you?
The best way to find me is on my website, which is yourgpsdoc.com. And I also love to connect with individuals on LinkedIn. So you can just search Nicole Rochester, MD, and connect with me there.
And of course, I'll have that in the show notes. I will also have her TEDx talk, which you need to watch. I will have that also in the show notes. So all good stuff coming from the bottom of my heart, Nicole, thank you for being here, and thank you for the work that you're doing to help us close the health equity gap.
Well, Shannon, thank you for having me. I appreciate this opportunity, and thank you for everything that you're doing to empower women.
Yeah, I appreciate it. Well, thanks, everybody. It was good to see you. We'll talk soon.